Bismillahirrahmanirrahim. Gene therapy for inflammatory diseases of the lung. More recently, interest has centered on gene therapy on a potential or as a potential therapeutic tool in modulating complex pathological processes such as pulmonary inflammation. Genetic modification of critical components of inflammatory processes may be beneficial. For example, overexpressing anti-elastase genes may circumvent elastase-mediated lung damage in emphysema. Development of improved viral and liposome vectors facilitates the use of selective cytokines and blockers of T cell surface activation provide new therapeutic strategies in inflammatory lung disease. Candidate disorders for gene therapy for inflammatory disease of the lung include chronic inflammatory diseases such as idiopathic pulmonary fibrosis, bronchial asthma, emphysema, and chronic inflammatory diseases include acute respiratory distress syndrome, radiated induced pulmonary inflammation. In these cases, disease is a consequence of multiple genetic defects or of interlocutions between genetic and environmental factors or the response to a toxic stimulus. Therapeutic intervention must therefore be based on an understanding of the molecular pathogenesis of inflammatory response. Rationale targets include manipulation of the levels of either pro or anti-inflammatory cytokines, such as expression of tumor necrosis factor alpha, which is associated or which is increased in the setting of IPF and other inflammatory lung diseases. Systemic delivery, second type or second manipulation, is systemic delivery for soluble TNF alpha receptors or anti-TNF alpha antibodies, which was effective in reducing inflammation. Local delivery of soluble tumor necrosis factor alpha receptor gene has attenuated the local inflammatory response. Local or systemic delivery of inhibitors of other pro-inflammatory cytokines could be or could similarly be employed in a gene therapy approach. Many cytokines are potential targets, including interleukin 1, interleukin 4, interleukin 5, platelet derived growth factor, transforming growth factor beta, and granulocyte macrophage colony stimulating factor, GMCSF, macrophage inhibitory factor, MIF, AKF mediators sustaining the inflammatory response in ARDS. In contrast, interleukin 10 is an anti-inflammatory cytokine. Interleukin 10 is an anti-inflammatory cytokine able to suppress expression of a variety of cytokines by macrophages. Thus, interleukin 10 might be of general therapeutic utility in the blocking of immune response at the site of pulmonary inflammation. Number two of rationale targets include downregulation of the cell surface adhesion molecules, such as intra or intercellular adhesion molecule 1 and endothelial leukocyte adhesion molecule E selection, and the expression of these molecules on the surface of pulmonary vascular endothelial cells is upregulated in inflammatory conditions. The third rationale target is enhancement of host antioxidant defenses. It has been shown that adenoviral-mediated delivery of the anti-inflammatory catalase gene to pulmonary endothelium can provide augmented vascular antioxidant defenses, which would be of therapeutic utility for diseases such as ARDS. The fourth rationale, which include increasing the levels of endogenous antiprotease. Here there is activated neutrophil sequestrated in the lungs release neutrophil elastase, which can degrade almost every connective tissue component of the lung. It has been shown that the release of neutrophil chemoattractants from human airway epithelial cells exposed to NE was prevented if the cells were transinfected with human alpha 1 antitrypsin complementary DNA prior to elastase exposure. This suggests that general anti-inflammatory properties of antiproteins could be exploited for gene therapy. Now, upregulation of production of anti-inflammatory prostanoids, which include prostacyclin and prostaglandin E2, which inhibit anti-inflammatory effects, which could be used to treat chronic or acute inflammatory lung disease. Patients with IPF has a diminished capacity to synthesize this prostanoids due to deficiency of prostaglandin synthase, and expression of these prostanoids in the lungs increase after delivery of the prostaglandin synthase gene into pulmonary artery using cationic liposomes. Upregulations, upregulation of prostacyclin, the prostaglandin E2 protects the lungs from endotoxin and pulmonary edema was markedly decreased.